Hello and welcome to the forum at the Harvard School of Public Health. I'm Abigail Trafford, your moderator. I'm a journalist and an author. And I want to wish everybody a happy International Women's Day today. And so it's very fitting that today we are going to talk about mammography screening. The title is Mammograms, Who in the World Are They For? My panelists are Dr. Mette Gallagher, researcher and lead author of the New England Journal of Medicine article offering a new assessment of mammography's effectiveness in reducing death rates. She's also a surgeon at the Oslo University Hospital and a visiting scientist at the Harvard School of Public Health. We have Felicia Knoll. Felicia Knoll. She is director of the Harvard Global Equity Initiative, and she's leader of the Global Task Force on Expanded Access to Cancer Care and Control in Developing Countries. Next to her is Dr. Flavia Bustera, Assistant Director General of the World Health Organization and in charge of Family and Community Health. And from Seattle, we have Dr. Julie Graylow. She is Professor and Director, Breast Medical Oncology, University of Washington, Seattle Cancer Care Alliance. She's an associate member of the Fred Hutchinson Cancer Research Institute. And how we're going to proceed is that each panelist is going to talk for 3 minutes about their work. And then I'm going to ask a few questions, and we're going to talk among ourselves, and we're going to get the conversation going, and then I'm going to turn it to all of you, and we'll have questions. And this is a very important topic. Mammograms, who in the world are they for? So let's turn to you, Mette.
Yes. We published a study this fall in the New England Journal of Medicine where we assessed the Norwegian breast cancer screenings program reduction in mortality from breast cancer. And the program started in 1996. And it was rolled out in a staggered fashion. So we were able to have two groups of women with those who lived in counties where the program was established and the control group of women living in counties where you didn't have mammography screening. And the screening program offers mammography screening to women aged 50 to 69 years old every second year. But in addition to that, in order to be a part of the program, each county had to reorganize the care for breast cancer in each hospital. So they established breast units and multidisciplinary teams. And we compared then the groups of women who were offered mammography screening with the groups who were not offered mammography screening through the period 1986 to 2005. And what we found is that we found a reduction in mortality from breast cancer among those in the screening group, 30%. However, we also found that the reduction in mortality in those counties where the program wasn't implemented was 20%. So the difference between these two groups is really the screening program, and that was only 10%. Mm-hmm. So a 10% reduction in mortality from breast cancer in the age groups 50 to 69 years old. But further, we also found an 8% reduction in mortality from breast cancer among the women aged 70 to 84 years old. They were not offered mammography screening, however, they were taken care of by these multidisciplinary teams and the breast units. And the multidisciplinary teams are doctors, specialized doctors, radiologists, pathologists, surgeons, and oncologists meeting every week, discussing every single patient admitted to the hospital, regardless of age. So we think the 8% reduction could be explained by introduction of this reorganized breast care. So 10% is significantly less than what we anticipated, and as previously been found, the U.S. Preventive Service Task Force estimated the reduction in mortality from breast cancer in the age group 50 to 69 to be 15 to 23%. and we found 10% reduction in mortality.
It's really important that this is about screening.
Yes.
It's not diagnosis. That we're just talking about screening asymptomatic, healthy women
Exactly.
for breast cancer.
Yes.
And we're talking about yes.
Yes,
So,
it's Norway.
It's Norway.
It's a Western world, and we have a public healthcare system. And also, I just want you also to remember that the goal of mammography screening is to detect breast cancer at an early curable stage. However, if you don't have the facilities to cure people, there is no need to screen for breast cancer.
Well, now let's turn to other parts of the world, and I want to turn to you, Felicia. Please give us your work and how you look at mammography screening in low-income countries.
Thank you, Abby, and for the opportunity to be here today on International Women's Day. I have to say, and I certainly hope, that mammography worked for me. So I was diagnosed with breast cancer 3.5 years ago in my first baseline mammogram at age 41 in a small clinic by a technician in Cuernavaca, Morelos. And if anything saved my life, in addition to Julie, it is that mammogram that was recommended by my friend and gynecologist who said, we're going to apply the standard guidelines and suggest that as of age 40, you start having your mammograms. That's the anecdote. I think the question, Abby, is what's the evidence here? I actually think that in reading this study and going over the editorials that were published in the New England Journal along with that study, what we're actually seeing is that countries like Norway, as Julio Frank would say, are in fact victims of their own success. What we seem to be seeing, and this I think has not been pushed forward enough, is that the results are actually suggesting that perhaps at the beginning, at lower levels of income, when you have a large mass of undetected cases, when awareness can be promoted, there can truly be a very large effect, larger than what we're seeing years later, after many years of work in a country like Norway. We have a tremendous difference between the high-income countries and the low-income countries. I reviewed the figures from GlobalCan from York for just 2008, published only last year, and I looked at Norway versus the lowest income countries and the lethality rates. The simple ratio of mortality to incidence, it's 14% if we look at those simple data for Norway, and it is between 48 and 55%. So the probability of survival is just tremendously different. What we are seeing, I think, all over lower and middle income countries is a disease that seems to be quite different, perhaps because of the disease itself, but perhaps because of the structure of population, the education of women, and the way that the health system works. We do know that going against what we see from the data, a much, much larger proportion of young women with breast cancer in developing countries. It is 55% below the age of 54, compared to about 30-something percent, the low 30s, in high-income countries. The differentials in age of death are even more upsetting, and those perhaps are a series of different reasons. The question we have to ask, I think, in developing countries, and we don't really know the answer for this, we're about to start actually a global study on this, is why are we seeing so many young women with breast cancer? It may be demographics. If it is demographics, that doesn't change the reality for the policymaker today. What it's saying is that you have a lot of young women with breast cancers that are terribly aggressive, very likely to kill them. We've seen in Mexico, I think, an unfortunate fallout of the recommendations, in fact, in the United States that weren't accepted in the United States by many, to change the age in mammography. The existing norm and recommendation, what we would desire for Mexican women, is the current norm, 2002, which suggests mammogram at age 40. There's now a tremendous debate to increase the age to 50 and every 2 years. And this is in the only country, the only developing country in the world where every woman detected with breast cancer has the right to complete financial protection, health insurance for all, to get the same treatment that I did without having to pay for it. It makes very little sense to be under-investing in early detection, where we know we have so many young women, and over-investing in treatment that won't necessarily save their lives, and we know that it could have. The logic seems to be missing, speaking as an economist, but also as a patient. Finally, the last point is that when we speak to women about why they don't explore their own bodies, why they don't insist on breast clinical exams, why they don't go for mammography in developing countries, it's terror. The terror of being maimed by mastectomy, the terror of an amputation, the terror of being abandoned by their husbands or partners, the terror of what they don't, and the surety, they're absolutely sure that they'll die of the disease. It doesn't seem to make any sense to then put on another barrier. We have enough barriers. I think we have to try to pull all those barriers down.
Thank you. Yes. Well, this is a very good segue to you, Flavia. Let's talk about your work and how you look at it from the UN. Sorry, from the World Health Organization.
So the World Health Organization advises countries on the policy that they are most beneficial based on the level of disease and burden that they have. And as you have heard from the two previous speakers, the situation across the world varies enormously, both in terms of the frequency and the incidence of breast cancer, but also most importantly, as Felicia mentioned, in terms of the capacity that countries have to respond to this burden. And as we discuss the issue of mammography and who is it good for, I like to start our discussion by positioning that this is one of the health problems that affect women in the world. And in fact, if we look across the world as we speak today, 1,000 women will die by giving birth. So we need to understand the investment we are making in women's health and the investment that can in fact pay off and the capacity that countries have to make those investments. So from the World Health Organization, we currently have recommendation to program manager for breast cancer to actually have mammography at the age of 50 every 2 years, and that was based in 2006 on the evidence that was available. As you understood, this is a field where evidence is changing, and what we do normally is we bring together the scientists and the results of this evidence, and then we periodically update. So we will be looking at updating these guidelines over the next year, because most notably what we also need to say is that data and research from the low-income country is very lacking. There is quite a number of research, and Mette has alluded to the very notable study she has conducted, but there is quite a significant number of studies that were conducted in the northern part of the world. But we do not have the same level of evidence when it comes to countries in sub-Saharan Africa and in Asia, and therefore creating guidelines is quite complex, as you may imagine.
Thank you so much. I would turn to you, Julie. You could tell us a little bit about your work.
I thought I would review the Breast Health Global Initiative guidelines, on which I've been a collaborator, not a main driver, but for discussion purposes. And I'll start out by saying I agree with everyone that the benefits, the gains we've had in the United States and in Western Europe with respect to survival of breast cancer have really been both the earlier detection as well as better treatment. And I think that's some of what we're seeing. So the Breast Health Global Initiative has established some guidelines for breast health care in low and middle income countries. And this is trying to be evidence-based, but also expert opinion and culturally sensitive. The Breast Health Global Initiative has categories of prevention, early detection, diagnosis, and treatment. And within early detection, the topic today, there are 4 levels that are suggested. The first is a basic level, then a limited level, then an enhanced level, and then a maximal level. We hope we in the US are at a maximal level, although I'm not always sure, certainly not a lot of our population. So at the basic level, the Breast Health Global Initiative suggests that the bulk of detection is going to be done by clinical history and good clinical breast exam. So creating some culturally sensitive education for the public and really putting efforts into the training of healthcare providers in terms of doing clinical breast exam and educating their patients. That's what should be focused on. Now, as the country is ready to move up to the next step in early detection, the limited step, here you want to start looking at diagnostic ultrasound and mammography. So for women with symptoms or a positive clinical breast exam, you have the capability of performing these tests. You're not doing screening, and you might do a first set of pilot projects on screening mammography in a target population, such as maybe women at the highest risk. So you're getting ready for the screening mammography, gearing up to be able to do, for example, the biopsies that you can't feel, you can only find on mammography. Moving to the next level, the enhanced level, this is where you start doing routine screening mammography in addition to the clinical breast exam and the education of the healthcare providers and the public. And currently in the Breast Health Global Initiative, the screening is recommended approximately every 2 years from 50 to 69, and then consideration of screening from 40 to 49. And if you do it in that age group, it's suggested that there's some evidence that it should be done more frequently than every 2 years. Now, this is interesting. I've seen it rolled out in some countries where a mobile mammography might be used, because while the country's ready to invest in doing screening mammography, there aren't enough radiologists and pathologists to support that. So they'll send a mobile mammography van out, and yet the readings are done in a centralized place. Any abnormalities are worked up at a centralized place. So we're ready to go out and do the screening, but we don't really have the pathologists and radiologists to be broad. They need to still be centralized. And then the maximal level is annual mammography that's being offered to women over 40, and other imaging potentially in high-risk groups, such as the patients with a strong family history for breast cancer, and implementing screening MRI here. The risk-benefit profile at any of these levels is going to weigh out differently, and as we've discussed earlier, Felicia brought it up, in a lot of these countries with low and middle resources, women are being diagnosed at a very young age. So these cut points for 40 or 50 are really pretty artificial and are predominantly based on kind of more Western or higher resource level countries in terms of the age that breast cancer is being diagnosed at.
Thank you so much. I want to turn to you, Meta, and let's talk about high resource countries.
Right.
And that is, what are the implications of your studies for the current guidelines in the United States, which are more frequent than certainly the World Health Guidelines?
Well, first of all, I need to, I'd like to comment on something you said, if that's
yes,
okay.
absolutely, absolutely.
Because you said that the incidence mortality ratio was different in the developing world and in the, let's call it, Western world. And you say that is due to maybe mortality, but it could be due to incidence. And it could be due to the fact that we have higher risk in the Western world. But it could also be due to the fact that screening over-detects cancer, which is one of the harms of screening that we cannot forget in this discussions. There are benefits and there are harms. And I think we might come back to that. I just needed to point that out, that it's not as simple to look at the incidence mortality ratio and compare that. You need to, and only to focus on the mortality. It could be something about the incidence as well. So that we're artificially heightening the incidence in the Western world due to overdiagnosis.
Just let's talk more about the harms.
Okay. Based on the U.S. population and the 10% mortality reduction that we found in our study, it was an editorial that you were talking about in New England Journal of Medicine that summed up the benefits and harms of screening. And the benefits was that you had to screen 2,500 women age 50 for 10 years to avoid one breast cancer death. The harms is that you have 10,000 women, out of those 2,500, 1,000 women who will experience a false positive test. That is, either you have to redo your mammogram, you have extra ultrasound, or you have to do a biopsy, or even an excision biopsy, which is really surgery. And then 5 to 15 women out of those 2,500 are being overdiagnosed. That is, they're treated for breast cancer, and that cancer, if they hadn't attended a screening, that would never bother them. So they have all the harms of treatment and none of the benefits. In addition to that, and that was not quoted in the editorial, but you also have false negative findings. And based on the Norwegian data, 25 to 30% of all cancers detected in a screening program is detected between screens. Interval cancers. They're actually attending screening on a regular basis, and 25 to 30% of them have cancer not detected at the screen, and they don't have the benefits of being detected early. So that is the picture how it is. And I think, at least in the Western world, and probably all over the world, it's very important to inform women about these consequences, the benefits and the harms, and to convey that in a way or fashion that they actually understand it. Because a 10% reduction, what does that really mean? So I think that's really the issue. And then we can talk about screening intervals. And based on our study, in Norway, women are screened every second year from 50 to 69 years old. So we're following the recommendations from the WHO, and we're also the new task force recommendation who recommend women below the age of 50 to be screened on an, let's say, individual based, talking to the doctor basis, and from 50 to 69 every second year, and or 50 to 74 actually every second year, and in older women more on a risk-based factor. But we have to remember that the incidence, at least in the Western world, is really increasing with age. So but that's different in the developing world, of course.
Let me throw out something really provocative. We hear this all the time: catch it early when it's curable. And I get the sense in reading some of these studies that that position is being modified, and that that maybe as important as when you find a cancer is what kind of cancer it is, and having the technology to be able to say, well, what kind of cancer is it, and what is the makeup of the cells, and then how do you target the treatment for that individual's cancer, and how does that change, you know, that understanding of cancer and the advances in treatment? How does that change, in a sense, the assessment of mammography screening?
Well, if you look at the Western world again, it seems to be like in the 1960s, 70s, 80s, where they started with the mammography screening, the breast awareness might not have been as high as it is today, and treatment has definitely changed over that period of time. And it seemed to me that the evidence seems to be that mammography screening plays a less and less role in reducing mortality in these countries in the Western world. And also, I think if you look at, let's say, testicular cancer, you don't screen for that because you cure everybody, so you don't need to screen for it. So it is a matter of what kind of treatment you can offer and what kind of individually tailored treatment you can offer the patient.
Julie, I'd love to have you jump in here to talk a little bit about, you know, catch it early when it's curable, that phrase, and also how do you advise individual women in light of the sort of the changing science of both breast cancer and of screening?
I think you asked a good question a few minutes ago about the difference between staging, which is the size and whether it's spread to the lymph nodes and beyond, and the biology of the cancer. And it's very clear that there are some very tiny cancers that are just bad biology and are destined to relapse no matter how early you find them. And we're striving to better understand those cancers and get better treatments. But it's also clear that the stage, which is the size, the lymph node spread and all, is also very important in terms of predicting risk of recurrence. And so earlier detection can impact those. I've had patients who have had very aggressive large cancers. For one reason or another, they've ignored, hadn't had healthcare access, etc. And still years later, it never spreads, it doesn't come back, they're highly curable. Even though it's been there for a long time, it's grown quite large. So we're struggling to understand the biology behind the stage, etc. I'd like to augment the risk and benefit discussion that we had, and clearly the most clinically relevant endpoint when we're looking at mammography trials or any kind of early detection and screening trials is going to be, are we reducing deaths due to the disease? But I would throw in, and I'm not sure this was properly discussed in our Institute of Medicine report and some of our guidelines, that there are some other benefits besides just reducing deaths. And earlier detection can reduce in-breast recurrences that are highly curable but still need more treatment. The smaller the tumor is, the better the chance that if you do, for example, breast conservation or lumpectomy, that it won't come back. Additionally, if you find a cancer when it's smaller, you have a higher likelihood of being offered, at least in countries that can do it, a lumpectomy as opposed to a mastectomy, so not needing to lose the entire breast. You'll have a higher likelihood if the tumor is earlier stage of not needing chemotherapy. And I think that's a big benefit. It's hard to sort any of that out, the mastectomy versus lumpectomy rates, the chemo or not, the radiation or not, in these trials, because essentially death was the main endpoint. But those are big benefits. I know my patients would clearly prefer to not have to undergo more aggressive treatments. Additionally, in the risks, I think we have to be careful about how much weight we put on the different kinds of false positives. And the need for a biopsy of something that ends up being benign, that can have physical and emotional impact, and each woman is going to weigh that differently. But sometimes a false positive, and a lot of the false positives reported in these studies, is they just need to do an extra picture, an extra view. It wasn't quite clear whether it was something you needed to go after, and just one additional mammogram would clear it up. And so there might be some emotional concern there, but really there's no physical impact or detriment to the one extra view. I agree about the false negatives and the false reassurance about missing a cancer. I've had patients who have said, well, I've had a lump for 3 months, but I just had a mammogram and it was negative, so I didn't follow up on my lump. And so there's some false reassurance. And then I don't know how to weigh the over-detection piece. That is clearly happening, especially with in situ cancers that never would have progressed, and we clearly have to sort that one out.
Yes, yeah, absolutely. Well, let's turn to the world again, to low income and middle income. We have a recession. Money is tight. So to improve women's health around the world, where does mammography screening fit in? Both of you.
Let me jump in, and also, if I
Yes.
can, I wanted to also comment on
Sure.
one point, which I think is absolutely crucial. Why screen if you don't have access to complete treatment? I have to say that I completely disagree with the idea that you should not screen or increase awareness if there isn't access to treatment. We're here in International Women's Day. If we are not telling women and other human beings what diseases they may have, we will never have the push, the demand that we need to insist on access to treatment. So keeping people out of their own business, which is their health, I have to say that I can't agree with. It's a terrible thing to have to face women and say, there isn't enough money, you can't get full treatment. But there's always something we can do, but I think that the solution is not to tell her. The second is, I did want to say something also about the mortality versus incidence ratios. That's a ratio. So clearly it's comparing two things, mortality and incidence. I think what we have to realize here, the bottom line is we have very little data, as Flavia said, for much of the developing world. But we are clearly seeing that we have a very different pattern of disease for several possible reasons, we don't know why, and a different set of health systems. And I think that all the evidence from your study is pushing to the idea that many particularly higher middle income countries would do a good job if they thought about investing in mammography for early detection. That said, being also an International Women's Day, there's much that can be done, and Julia suggested this with the Breast Health Global Initiative guidelines. We are seeing 60 to 70% of women with breast cancers that will kill them and do kill them. That's why those rates are so high, the mortality to incidence. There's a lot that can be done even where there's no mammography. This is about awareness building. This is about training your primary level of care. You do not need an oncologist to earlier detect the kinds of tumors I see in the field on a daily basis, which are lumps that are larger sometimes even than the other breast. We could do a lot better in many ways. But I think the bottom line here is what we're talking about is investing in women, and often in young women, who are in their most productive and reproductive stages of life. And therefore, if we talk about economic crisis, I think we also have to talk about investing in women as a way of pushing ourselves out of longer-term economic crisis.
Right, but let's just go back to this screening. That is sort of using a technology like mammography. Is that kind of like a technical Trojan horse, in a sense, to increase awareness of breast cancer and other diseases and get women into health centers and lead to better health care?
I think that some of the discussions were suggesting that the effect that we could have been seeing with mammography is partly how that increases awareness. That's not the suggestion that I'm making here for developing countries. What I am suggesting is that anti-poverty programs, women in health programs, health promoters, nurses at the primary levels, and physicians at the primary level can do a substantially better job than they're doing today, even if there's no screening mammography available, to help women to better understand this disease. And in fact, in doing so, to better understand our own bodies and better advocate for ourselves within the health sector. Breast cancer is just the tip of the iceberg for what women suffer in terms of barriers related to machismo and discrimination. So even where you don't have this, what is supposedly a Trojan horse, there's a tremendous amount that can be done among bringing women forward.
Right. Well, Flavia,
Let me tell
talk
you,
about,
yes,
yes,
let
you
me
talk
tell you
about integrate these
what
services.
my colleague and friend from Uganda told me today, which is, he's a gynecologist and professor that is an advisor to the president of Uganda, and he's very interested in this topic, but in his hospital, which is a central teaching hospital in Kampala, he cannot offer mammography. So your question is, he cannot offer. What place does he have? But what they are starting to do, which is very, very promising, is that with very limited support, they are trying to educate primary care providers, and especially midwives and lower level cadre, to speak to women, to educate them, increase their awareness, to use every opportunity that when women have access to healthcare providers, that let's not forget that in many parts, for example, of rural Uganda, women don't access healthcare services every day. In fact, they have initiated this program where healthcare providers go to women and they don't talk only about breast cancer, they look at their whole health, their reproductive health. They advise women about, for example, what are the choices about their fertility, what are the choices they have once they become pregnant in terms of the care they can have for the delivery, for themselves and for their own children, because women are in fact, in most parts of the world, the primary providers and carer for children themselves. And I quite agree, and I would like to comment on this point, because when in the discussion with him, the issue of I can't offer mammography and therefore there is no point in me detecting a woman with breast cancer, I cannot offer treatment afterwards. It's reminded him very much of where Uganda was 10 years ago with the discussion around HIV/AIDS treatment. And 10 years ago in Uganda, the scenario was similarly where, okay, we cannot detect HIV/AIDS, we do not have the laboratory, the facilities to do so. Even if we could, in the small project where we are financed by development agency from outside our country, we cannot treat these patients. And now, in the global response to this disease that is being considered a priority through the impact and effort of many schools in the world, and many of the development agencies, my own organization that in fact had an initiative 3x5, 3 million people on treatment by 2005, we have millions of HIV/AIDS patients that are actually receiving lifelong treatment. So what I would like to say on Women's Day is that we need to have that kind of horizon in countries where currently, unfortunately, physicians and professors like my colleague Pius Okong cannot offer the treatment, but they have that perspective. And from the outside, from the agencies that we are here and from the university and the school, like the School of Public Health, we need to advocate and prepare policymakers for being able to offer women the care that they deserve, and they have the right to. And they have no access to that care because they happen to live in Uganda and not in Norway.
Right. Well, so you're calling for really a movement to find the resources in the world to address the issue. But now I want to go talk about what the issue is. Is it women's health generally, including reproductive health and cancers and heart disease? Is it breast cancer? Or are we talking about, but then we're talking about screening mammography. So where do those three elements fit in this call for more resources?
Abby, I think that what we're seeing in the discussion in the Global Task Force and a model that we've been using more and more is what we're calling the diagonal approach. This was originally written about by Jaime Sepulveda, who's now at Gates, and by Julio Frank. The idea that it's either the vertical or the horizontal, the health system interventions or the disease specific, is now really very passé. We, I think, know that in order to effectively meet the challenge of a disease, be it the prevention, detection, survivorship, or treatment side, we need to also be investing in strong health systems. And that's not about saying, I'll pick only the women sitting in this clinic who have breast cancer and help them. It's about seeing the different diseases. We're also seeing that it's very passé to talk about only neglected communicable diseases. Paul Farmer said the other day, let's face it, in developing countries, every disease is neglected. That's probably the truth. But it's also true that the poor suffer more from all diseases. So we need to change the way we think about that. It's a more complex model. It's also one that I think is more ethical and more effective.
But then returning, say, to the U.S., breast cancer is very disease specific, and we have many organizations around breast cancer, and we think of that disease, and then also mammography. Mammography is just very precious for American women, and we've grown up with, if you care about your mother, make sure she gets her mammogram. And so what I'm sort of saying, well, what's happening now? You have a global initiative, which sounds to me includes much more than mammography. But now we're talking about mammography screening in this country and the technology. And so where are we going with screening in this country?
I just want to make one point to recall in our study that we found 10% reduction for those who had both undergone mammography screening and been treated by the breast units and specialized doctors, and 8% reduction, almost the same for those who had not undergone mammography screening. So I think, just to back up on the screening point, the healthcare system, extremely important, and then when that is in place, we need to discuss screening, because screening is something else than offering healthcare system. However, it could be that greater awareness, not only about breasts, but about your body is a good thing. But I think the establishment of the healthcare system is more important than talking about screening, because it seems that the harms might outweigh the benefits, or at least it's a close call. So I think we need to have that in mind when we discuss, even in the developing countries.
But in this country, when the task force recommended less frequency of mammography, it caused a political firestorm, and agencies rejected it. And so can you talk a little bit about why and what can be, because we as consumers, it's very confusing is all I can say. So I'd like each of you to tackle that.
One thing, I think that Julie was alluding to this as well. Why did we ever pick round numbers? The evidence between 40 and 50, 40 every year versus 50 every 2, there's an enormous gap there with very little evidence. And so why didn't we pick 43 or 47, which might be the ideal number? Is it because it's not rounded? There's a series of issues there. I was diagnosed in Mexico, and this is the situation that I can speak to. But I have to say that I would not have given up the opportunity to have my mammogram at age 41. And I think many women who cried out to continue felt that they could manage and want to continue to manage whatever that anxiety might be, because we have a fear of this disease that has certainly killed many. What I think is changing very quickly, and perhaps hasn't permeated, is how effective we hope the treatment is and can be when it's personalized and specialized. And I have to say hope, because I've gone through all of the treatment, or most of them other than radiation, that Julie was alluding to. And we believe and hope that that was very effective. This, as you said, Abby, is new. Now, for women to believe that even if they're detected a little bit later, that treatment that they'll have access to in certain countries can still change their life, may make them decide that they don't want to go through that much screening. But I don't think we've permeated with that message yet. We still have the belief, and it's still the case for many, if you don't have access to that treatment, that you're not necessarily going to be that lucky. And so you are on the side of what Julie suggested, that we still know that if we're detected earlier, it's better. One last point there is that I cannot speak enough to what it must mean for a woman to be able to avoid 16 rounds of chemo, which is what I had, and a mastectomy. And would I have possibly gone for yet one more mammogram if I had been able to avoid that? Much as I think I learned and we shared and grew as a family, I would have done a lot to have avoided that.
Well, I think it's a, you know, we're talking about human beings, and this is one of the issues when we talk about public health and population guidelines. We're talking about, you know, huge populations, and of course, when we talk about getting sick, we're talking about individuals and their experience of the illness, and so I think that's what makes this disease and makes the screening issue so difficult, because when we say screening and mammograms, we think of somebody. And so then we sort of turn to scientists and you researchers and clinicians to then sort out the evidence and then see where do we fit in that evidence. Let me bring up one issue before turning it over, which, and that is costs. What about the cost implications of mammography screening?
I think Felicia, who is an economist among us, is the best person to answer this one.
I can try to speak to that, Gabby. It's, there are very few studies in developing countries. There's one in Mexico that was done by set of colleagues and close friends, led by Stefano Bertozzi at the National Institute of Public Health. And what that showed by comparing and modeling mammography at age 40 versus 50 was that both were cost effective. So in fact, mammography beginning at age 40 every year, every 2 years, or age 48, were all cost-effective in the guidelines suggested by WHO and the Commission on Macroeconomics and Health. In fact, age 50 every 2 years was not cost-effective. This was in that study in Mexico. We've done a few other studies, but they don't come as close to being cost-effectiveness studies. The key here goes back to, I think, more than cost effectiveness. If you are late detecting, investing a lot in treatment, and you have a 1 in 3 chance of 5-year survival, your effectiveness drops tremendously. So earlier detection associated with mammography, but let me stress also not only mammography, the breast clinical exams, the awareness, the knowing your own body, the access to treatment, increases effectiveness tremendously because you increase the lifespan of women. That's really the bottom line, I think, in those measurements. I can't speak as much to the US data on cost effectiveness. I would leave that to my colleagues who do more on high-income countries.
Well, let's turn it to the audience. I'm sure you have questions. We've thrown out a lot of different bits and pieces about mammography screening. How about some questions? Yes, Robin.
Hi, I'm Robin Herman. I'm director of the forum, but we have some questions from our online audience, so maybe I can start with one of those. We have a question from Dr. Enrique Sanchez at the University of Toronto, Canada. and the Institut Nacional de Cancerologia de Mexico. He wants to know if a true national registry system does not exist in Mexico, how can one be sure that breast cancer kills more people than another major public health concern, which is cervical cancer?
I guess that's
you. So thank you very much for the question. First, let me say that we need more registries. We have only a precious few in particularly the developing world. Every country does not need a full national registry, but we do need more. It is true that in Mexico there is no registry. There's only one state in the country, Jalisco, that has a registry that we're trying to bring up to speed. And in fact, that's a project that we're doing with work here from the Harvard School of Public Health, Harvard Medical School, and the National Cancer Institute, and the Popular Health Insurance Seguro Popular in Mexico. Why am I so sure of those numbers? And we've published them rather extensively. It's almost the stigma of the work that we've been doing in the NGO that we work with, Tomatelo a Pecho. It is because they're based on mortality figures, not on incidence. We've looked at trends in mortality, and I have to say that this is part of the work of a truly excellent epidemiologist, Rafael Lozano, over 50 years. What we've seen is actually extremely good news in Mexico on cervical cancer deaths that have dropped from 16 per 100,000 to 8 since between the early 90s and 2006. And the breast cancer figures have simply either continued to go up or plateaued at a certain level, so that as of 2006, more women die of breast cancer than of cervical cancer. But there are two parts there. One is what's happening with breast cancer. The other is how well we're doing on treating, early detecting, or in fact detecting precancerous cervical issues where we know that we can save women's lives. There's a real success story in there. I think there's also a message, which is when I hear colleagues who argued in Mexico and elsewhere for screening, Pap screening in Mexico, and they said this will never happen, they see that graph and say, look, and it did. The question is, can we do something like that on breast? So the quick answer is that they're not based on incidence, they're based on mortality figures, and we do have, I think, a very good mortality series in Mexico.
Another question.
Lucas from University of São Paulo. I'd like to ask you about a more practical question about design. When we talk about delivering mammograms to these women, so we're going to their communities and asking them to have these mammograms, we will have a mobile device that will get these mammograms in their communities. How do we think about the size? Like 10 million people in a city like São Paulo, and we're offering like one of this kind of mobile device will offer in terms of number. How do we design this project, considering that these women have never gone to this kind of exams?
Who would like to take that?
Well,
You have
Yes,
come back to
Betty.
one.
yes, I'm not sure that I understood your question. Is it that how do you design a research on implementing mammography screening in this setting? Is that what you asked? Well, I honestly think randomized controlled trials is the answer here. There's so many questions about mammography screening. The field is full of emotions. We have a lot of facts. 10% reduction in mortality. We stated the harms, the overdiagnosis issue, the false positive, the false negative. We need studies that are conducted on a randomized control basis. Again, even though they were conducted for the screening field, not very many other fields of screening for cancer are based on randomized controlled trials, but I think that's the way we're heading. We need to go to the randomized controlled trials.
I would agree with that and suggest that we need at least one of those trials in an upper middle income country. We may see very different results. We may see results similar to yours in 20 years in that same country. But I think the question is a little bit now. But I thought if I understood correctly, you were also asking the question about how do you implement a program like this. Am I correct? That's not an easy question to answer. We are working closely with the National Cancer Institute, with the National Commission for Social Protection and Health in Mexico, in several states, to support what's being done in terms of screening and promoting earlier detection, to shore up what's being done on treatment. Part of the answer, and the part that I really want to stress with you, is that it's not only a supply side issue. We have mammography machines in Mexico with technicians to read them that are being underutilized, in part because women don't want to go. And when I've tried to convince them to go, they say, why would I want to know? Because if I find I have breast cancer, my partner will leave me, and I can't support the children, and I'd rather die of the disease than find out I have it and figure out how to manage it. Or I've had another woman say, a woman without a breast is ugly, and I don't want to be ugly. Now, being a woman without a breast, the question is, how do we get over those kinds of conceptions, that kind of stigma, and further, how do we prove to women that if you actually are diagnosed, you have a chance of surviving, a good chance of surviving, so it's worth investing in that. It's worth investing in the prevention and in your own health. That's something that we often, I think, as women, don't do enough of in general. And certainly when we're talking about cancer, we don't do enough of. So what I'm getting at is, for that screening program, we need the participation of men. We need to understand what women feel in terms of stigma and about their own bodies. We also need to work on the demand side so that women are pushing to be able to be diagnosed early enough if they have these sorts of diseases to get treatment.
But here's the question. Do you need mammography screening to do that, to overcome stigma, to bring women into a healthcare system, to talk about their bodies? Couldn't you do that with other ways and not have a mammography machine?
I think you need
For
both.
screening, not for
think you need
diagnosis, but not for screening.
I think you need both.
Why do you need both?
First, because you need to demonstrate that women can survive. I think why our stories are powerful for those of us who are still living with this disease is when we can stand up and say, we went through the treatment, but we're still here. You can do it as well. Now, if I hadn't had my first mammogram until age 50, I don't think, I'm only 44 now, almost 45, I don't think I would have gotten there. And I might not be here at all. So I don't think it's an either or. That said, the answer for a lower income country isn't if you don't have mammography, you can't do anything. But the reason is because if you have 60 or 70% that are today being diagnosed in stage 3, 4, these enormous superring cancers, a midwife with basic information can earlier diagnose and give that woman a much better chance, perhaps not at surviving the cancer, not at cure necessarily, but at a much longer life expectancy with healthy life with the disease. Let me say that for many of them, young women, again in developing countries, an extra 5 years with your children.
Couldn't you do that, though, with clinical exams, training programs? I'm trying.
I
So we're
think that's
talking
important.
about screening. Well, what do you think? Do you need mammography screening? And Julie, I'd like you to.
I don't know, because I'm not an expert in the developing world, but I know, why would you want to implement a program if you could do a randomized controlled trial?
Well,
You will
that's a
get
good
the
thing.
answers. By implementing a program, you might not get the answers. You might not have any research to back you up on your views. Right now, I think I need to stress this again, because I think the mammography screening field is a lot about beliefs, emotions. We need to look more into the research, the science behind it, and women need to be informed of the science behind it and what that conveys. What does this mean? And then they can certainly decide whether or not they should go to screening. And we're talking about screening mammography, not mammography, to stress that again.
Right.
So I think we have to back up. We have to back up and say, okay, let's start over. Let's start in the developing countries to do the research, to do the randomized controlled trials. It's feasible. It's possible. And
Julie,
that could heighten the awareness and get this effects that you're talking about. But I'm not an expert in how to get the women to attend and to be part of a trial. So I'm going to be, I don't know that, but I think we have to stick to the science here.
Julie, please jump in here.
So I guess I'm just a little bit confused about what kind of randomized trials we're talking about. Screening mammography saves lives, and multiple studies have shown that. I think what we're getting at here is at what point is a country or a population ready to take this step? We can't do it in an isolated way. We have to go through the enhanced levels. We need to educate the healthcare providers, and we need to do good clinical breast exam, and we need to be able to do the biopsies and diagnose breast cancer before we jump in with routine screening programs. So while I think we need some pilot projects, and I think we need more understanding of how to implement and sustain a screening mammography screening project in some of these countries, I don't think we need more randomized trials looking at does mammography save lives. I think we've also got to package this, as we've talked about, in terms of the whole woman or the whole patient, and not take mammography out in an isolated way. So the healthcare providers, the promoters, whoever's discussing all of these issues with the given woman needs to be talking about risk reduction as well. I mean, I would far prefer to prevent a breast cancer than diagnose a breast cancer. And so some of these countries have very different risks for cancer in general than we do in the United States. But discussions about diet, body weight, physical activity, hormone replacement therapy, some are irrelevant in some of these developing countries, but they need to be part of the whole education of the woman when you're talking with her about offering a mammogram at the same time. And we're talking about individualization of risk reduction and screening and care across the board, and that's really hard to look at with a big, global health picture. We're talking about how we need to individualize even more, and we can't do one size fits all for any country, much less any given woman.
So, Abigail, maybe one conclusion of our debate is that, in fact, we don't have a world global generic woman that we are discussing in International Women's Day.
Right.
We do have a very different level of risk, as Julia said. For example, the fertility rates in different populations of women across the world varies tremendously. My own country, Italy, is one of the lowest fertility rates. We are below replacement level. We still have countries where women have more than 6 children during their own reproductive years. Then, for example, whether women breastfeed or not, and the other risk factor that Julie mentioned, all of these across the population varies tremendously. Then when we then look at how women are aging, and how long they survive, what their life expectancy is. And then we need to match that with the kind of healthcare system and level of ability that system has to provide care for women. So we do not have a solution that fits every single country and that fits every single woman. But what we are trying to convey here in this debate is that when country makes the decisions, they have to make those decisions based on the level of data that they have, and at WHO we try to bring data from different countries, so that countries like Brazil, for example, where they do not have data, maybe they can look at countries that have similar epidemiological profile and similar level of healthcare system. And also we are arguing that it's important to invest on the knowledge and on the research and on the data that underpin those decisions.
Yes, yes. I think, is there another question? Do we have? Well, I think this, yes, there's another question.
It's back to the online audience. We have 2 online viewers who are asking about primary prevention. Maynard Clark, who actually works here at the school, so he must be watching somewhere outside the studio. He says, are we able to compare the health benefits and cost savings or costs of screening by mammograms versus evidence-based lifestyle correction interventions, including behavioral corrections to reduce the risk of breast cancer? And similarly, Carmen Barroso, who's the regional director of International Planned Parenthood Federation, Western Hemisphere region, she's asking if we are talking about cost effectiveness, shouldn't we compare with the cost of primary prevention? As we probably know very little about this, should public policy consider investing more in research in primary prevention?
Who would like to take that?
Julie.
Julie, there you go.
Well, these questions may have come in before I made my last statements, because it's exactly the point that I'm getting at, which is that we need to incorporate primary prevention or risk reduction when we're looking at secondary prevention, which is essentially the screening with mammography. I don't know of any study that's randomized to educating about primary prevention versus screening, and I don't think we should ever do it. I think it makes sense to reduce our risk with respect to the things we can control as much as possible. And I think that a lot of, even in the United States, a lot of women and a lot of healthcare providers don't really understand all of the risk factors for breast cancer. And so we need to incorporate that, and then we can look at whether screening does anything on top of it or not, I guess is my point. We need more research into what causes breast cancer, but the current estimates by the American Cancer Society are that if we could impact physical activity and body weight and nutrition and alcohol, just those things alone, that we could potentially reduce deaths due to breast cancer by 25 to 30%. Just from those things. So it shouldn't be an either or. It should be, yes, live a healthy life, do the things you can to reduce risk, and then on top of that, see if more expensive interventions like screening, which have harms as well as benefits, are going to impact that.
Well, I think we're sort of coming to kind of a consensus here that we're talking about mammography screening, and yet we can't talk about it too much in isolation, that it really is part of an overall strategy to improve women's health. I still think mammography screening is such a buzzword certainly for Americans, that maybe we do need some more research about what about mammography screening, and what about the harms, what about the costs, how do you make public policy again, on the data. Some last words.
Very quickly, developing countries and all countries have to set priorities, and that's what a lot of this is about. One piece of data that is perhaps the piece that most shocked me. It turns out that breast cancer is the #2 killer of young women aged 30 to 54 in most of the middle-income countries in the world. The #1 is actually diabetes in most cases. This means that this is a high priority. I was certainly very surprised to see that it was so high on the list of killers of young women.
So we definitely agree with you, Abigail, that we are talking about breast cancer in the context of women's health, and that we look at it within the spectrum of all the other conditions that affect women. And if you allow me, I also wanted to say that within the World Health Organization, we have a heightened awareness that health of women has been not as important and prioritized by many countries. And in fact, in my own cluster that I lead, we have actually changed the name from family and community health to family, women and children health, to indicate that we are looking at the health of women starting from when they're born across the life cycle to the next generation. And in that, by doing that, we are hoping that in fact we can advise better countries for illnesses that in the past were considered neglected or not a priority, like for example breast cancer and other type of cancers.
Well, I think what's so interesting in what you're saying is that one size doesn't fit all, and really the challenge to the World Health Organization is setting priorities and setting policies for different parts of the population. But you sort of, you also can't have it, you don't want to tell, a woman in Uganda something totally different from a woman in Philadelphia, because they're both women. So it's a real challenge. It's a real challenge. Any more questions from the audience? Julie? Oh, Julie, I want you to also jump in here.
Well, just in conclusion, I would say breast cancer, has a lot of interest in the world, and I think we can use breast cancer to strengthen treatment of every other cancer. You put in place the treatment end and the diagnosis end, you're helping every other cancer out there. And to step back even further, if we can improve breast cancer prevention, detection, diagnosis, and treatment, we're going to strengthen health systems across the board as well.
And I disagree with you on the randomized controlled trials, because I think as we can see here, is a lot of questions we haven't answered yet. What age do we start? Is it a different risk factors in the developing world and the Western world? Should we start screening earlier? What is the benefits? What are the harms? And really, we don't know that yet. And we can't, in the Western world, where you have implemented screening on a population basis, you do not have the controls. You don't know what would have happened if you didn't have screening. And of course, you can use examples like you, and that as doctors we do that, but we need to look at a broader perspective. We need to look at the populations. So I think that the answer is, why implement a screening program if you can do a well-conducted randomized controlled trials? Whatever, you can change the age groups, you could do the screening intervals, you could do a lot of things within that screening trial instead of implementing a program.
Could I just, I think, I have to say, I mean,
it's controversy, right?
It's controversy. But the question is whether or not, one is my anecdote and the other is my evidence. But I think you really hit the nail on the head. The question is, can you say something different to a woman in Uganda? Is the woman in Uganda worth less than the woman elsewhere? And what we have to be very careful about, very careful I think, is the science is extremely important to guide policy. But you cannot ask, I think, a policymaker, a woman, to wait until we have a whole series of randomized control studies in developing countries before we're doing something about a number 2 killer of young women. We have a whole series of important ideas I think we've discussed about what you can do even when you don't have access to mammography. But as Julie said, the evidence is very clear that mammography does save lives. So I think we have to have the science and the randomized controls accompany what we're going to be thinking about in terms of policy. I also think we have to be very careful and beware of the conclusions that some are saying from the study, which is that it's wonderful that this is the case in high-income countries. The message is that this can be very effective still in low-income countries. That's a possible outcome of the study.
But we don't know that. We need to find that out. That's my
Yes.
message.
I think this, when I hear all of you talking, there's a real question. We're talking about mammography screening, a technology, and then we're talking about education, self-awareness, promotion, general health care, and all of that is, I don't think there's any debate that that's not a good thing to do. And so if you're talking about a study, you would compare people who are having the same level of prevention and education and care, and one group is getting screening and the other isn't, in a sense echoing the study that you did in the high-income country.
So if you have, we found that reduction among those not being screened aged 70 to 84 was almost the same as those who were screened aged 50 to 69. That could be the case everywhere, so maybe it's just the way we treat people and the way we organize the healthcare system.
But we're still left with, do we start at 40? Do we start at 50? Do we every 2 years?
Know.
Do we say no, we just don't do it because we're older, or it's not going to make that much difference because there are other factors going on? And I think this is, certainly public policy has got to come. I would hope, invite you to come up with some answers, because all of us women, we want to know, and all of the men who love us want to know too. I think it's a good note to end. I thank you all for coming. This has been a great forum, and we'll continue the discussion.
Thank you.